So we're just gonna pick up where we left off with our pediatric urinary system. I'm gonna try and get through much of this as I can. If I have to go through 11, we'll just start the next lecture half an hour later, but I definitely don't want to cover Wilms tumor in depth and polycystic kidneys. But anyway, so just to pick up where we left off, the next potential condition that you can encounter is something called a patent urachus. So I remember when I first got my first requisition that said rule out patent urachus, I was like, what is that? Like, I've never even heard of anything like that, you know? So I did a little search, and it's actually not such a difficult thing. It's not such a difficult exam. So the urachus is actually a long tubular structure which connects the dome of the bladder to the umbilicus. So this is a long tubular structure. Next, dome of bladder to umbilicus. The reason they order this exam is because these children will come in with an abnormal discharge coming out of their belly button, you know, like either a fluid or sometimes it's like more pus, but typically it's like a fluid, and it's essentially urine that's it's coming up that tubular structure through that pathway up to the umbilicus. So normally it closes during the 4th or 5th month of gestation and is often completely fibrotic by birth, or at least seals off during that neonatal period. So it's something that should be closed off and sealed, but it can remain patent in some patients, in some pediatric patients. So to kind of get a perspective of what it is you're looking for, so if I have my patients so if they're lying supine, you know, we're in long, this is your bladder, you're going to see a channel that connects from the dome of the bladder, the superior dome of the bladder, up to the umbilicus. So you'll be able to see a track of fluid that runs from the umbilicus to that dome of the bladder. So I typically scan in either transverse, try and see if I could see a little circle of fluid, or then I'll elongate it and try and track it down to the bladder and see if there's a connection to that bladder. You could potentially have one side seal off. So like, you know, maybe the portion near the bladder seals off and there's still just a little bit of fluid trapped in here. There may be a small segment that's still patent, or potentially the entire thing could be patent. This urachus can dilate pretty significantly and could be evident as a palpable mass. So you're basically just starting your exam, you know, I like to start at the dome of the bladder and just kind of work my way midline, just tracking my way up towards the umbilicus. So it's just going to run midline straight up to the umbilicus from the dome of the bladder, the superior dome of the bladder. So we'll here a tubular hypoechoic mass. Tracing umbilicus Bladder. And with the patent urachus, could be a cause, could be a cause or source of infection. If you think about it, if that's urine that's now getting lodged and stuck in this area, you know, over time that's going to cause an infection. So this exam's pretty easy. So that's a patent urachus. So that's a connection in the urachus, which is a tubular structure that connects between the umbilicus and the superior dome of the bladder. Normally, it becomes closed off and fibrotic, so this is going to seal off. And in some patients, it can remain patent and be a potential source of infection. Next is renal cystic disease. So under here we have our multicystic dysplastic kidney disease. Cystic, dysplastic. MC. So this is the most common cause of renal cystic disease in neonate when hydronephrosis is excluded. Renal cystic disease, hydro excluded. It's the most common cause of abdominal mass in a newborn. There is a congenital component to it and usually appears sporadic and associated with renal dysplasia. So what is it? It's when the collecting tubules enlarge and become cystic and they grossly distort the shape of the kidney. The remaining renal parenchyma is it's undiscernible. Collecting tubules. Dilate. Become enlarged. on a cystic appearance, which distorts kidney shape. The rate and remaining kidney tissue is non-functional. Nearly half of these patients will have contralateral abnormalities as well. So half will contralateral. Anomalies. As well. So the classic sonographic appearance is going to be that cluster of grapes. That's how we describe it. Described as a cluster of grapes. You're going to see multiple discrete non-communicating cysts. I know sometimes if a patient has a polycystic kidney, it can potentially look like hydro. So you want to look to see and differentiate between cysts versus hydro. You look to see if the cysts communicate with each other. So if the cysts communicate with each other, then you know that that's not cysts. That's actually more likely hydro. So to differentiate between hydro versus multicystic kidney. Look for communication between cysts. So with this, there is no communication. The largest cysts are usually located on the periphery of the kidney. And there's typically no identifiable renal pelvis. Largest cysts. Peripheral. kidney. Renal, pelvis, not visualized. So we can also have hereditary renal cystic disease. Hereditary renal cystic disease. So these may present in neonate or pediatric patients, and some of these include autosomal recessive polycystic kidney disease, recessive polycystic kidney disease. Autosomal dominant. Autosomal dominant. Cystic kidney disease. Tuberous sclerosis. Von Hippel-Lindau disease. Medullary cystic disease. So our autosomal recessive polycystic disease. autosomal recessive polycystic kidney disease. So the typical pathologic presentation is going to be diffuse enlargement of the kidneys, sacculations, cystic diverticula of medullary portions of the kidney. Most severe form seen in the neonatal stage. Least severe form is seen in infantile and juvenile stage. Enlargement. Kidney. Sacculations. Cystic. Particular. Medullary. Portions. Severe form seen neonates. So with the autosomal recessive kidney disease, polycystic kidney disease, the kidneys also appear hyperechoic. The representing cortex is comprised. The representing cortex is compressed by expanding pyramids. So we have enlarged pyramids, enlargement of the kidney. We have compression of the cortex by the expanded pyramids. The degree of renal cystic disease determines the severity of renal dysplasia, which can lead to renal failure and then eventually liver failure. So, sonographically. We have renal enlargement. Increased echogenicity. loss definition of renal sinus compression of cortex. I'm sorry, compression of medulla. So can affect liver, cause hepatosplenomegaly and portal hypertension. So the way this differs from the multicystic dysplastic kidney is these cyst-like appearance are related to the dilated tubules, and they're generally less than 2 millimeters in diameter. So they're quite small, whereas with a polycystic, multicystic dysplastic kidney, you're going to get much larger cysts. And you're going to have large cysts, you know, around the periphery of the kidney as well with the other one. And you'll have basically a complete, you know, replacement of the renal parenchyma by cysts. These cysts are smaller. So there is a noticeable change in echogenicity with the autosomal polycystic kidney disease. You will be able to discern some renal parenchyma. So you'll be able to measure these kidneys, whereas with multicystic dysplastic kidney, you may not even necessarily be able to get a true measurement on that. You know, it's hard to tell, you know, where the actual borders of the kidney are. So autosomal dominant now. The adult dominant form of polycystic kidney disease usually appears during middle age. It's rarely reported in young infants. It's now our autosomal dominant. So, so this is the adult dominant form of polycystic kidney disease. Oh, dominant. Cystic disease. Rarely reported in young infants. cysts macroscopic. And vary in size. So they're small. You're not going to have large cysts. And can also form in liver, spleen, and pancreas. So cysts are microscopic, vary in size, and also form in liver, spleen, and pancreas. And then there's something called a cerebral berry aneurysm that can occur in about 10 to 15% of patients with autosomal dominant polycystic kidney disease. It's a 15% and develop cerebral berry aneurysm. So renal cysts may appear in the kidney and may be found associated with various multisystemic syndromes like tubular sclerosis and the von Hippel-Lindau disease. Renal cysts. Here. Kidney. Cell. Various multi-systemic syndromes like tuberous sclerosis, and disease. So patients with autosomal disease of tuberous sclerosis have a 40% incidence of having renal cysts, which may resemble polycystic renal disease. Angiomyolipoma. So angiomyolipomas may occur and be multiple. Their echogenicity is determined by the amount of fatty tissue within the lesion. May appear lesions hidden echogenicity determined by amount of fatty tissue within lesion. In patients with von Hippel-Lindau disease, there are multiple cysts. Both tubular sclerosis and von Hippel-Lindau disease are associated with an increased incidence of renal cell carcinoma. Both sclerosis and disease associated with increased incidence renal cell carcinoma. Then we also can have medullary cystic disease and nephronothesis. Nephronothesis. So both of these two diseases are indistinguishable from each other. Both are distinguishable. Each other. Closely related. May be either autosomal dominant or recessive. Dominant or recessive. It can cause renal failure in a child or adolescents. Cause renal failure. With sonography, kidneys appear small and echogenic. Small, echogenic. Cysts of variable size are seen along the corticomedullary junction. Cysts I'm going to say cysts are concentrated. Long. Cortical medullary junction. It can be seen elsewhere in the parenchyma. So now I'm going to move on to something that's more common. You're definitely more likely to encounter in the clinical setting. That's going to be urinary tract infections. So oftentimes we'll get orders for pediatric and primarily infants, for renal ultrasounds, when they're diagnosed with their first UTIs. So these little babies that develop a UTI, we'll often get them to do ultrasounds to try and rule out, either cystitis, an infection in the bladder, or pyelonephritis. The kidney has made its way to the kidney. If the infection has made its way up the kidneys to the kidneys. So infection. Urinary tract. Maybe our UTI. Acute. Pyro. Yes. Pyelonephritis. Clinical symptoms. So the child's going to have fever, flank pain, potentially have dysuria. Urination. So infection usually begins in bladder. Descends ureters to kidneys. Send up the ureter into the renal pelvis. So on ultrasound, the renal size may be slightly enlarged with altered renal echogenicity secondary to edema. So as the infection spreads, there may be increased echogenicity in the renal pyramids. The renal pelvis and ureter may show some thickening secondary to inflammation, and infection may be diffuse or localized. Appearance. Sound. Enlarged. Altered echogenicity. renal parenchyma. Kidney, so here heterogeneous. You may also see some enlargement of the ureters and the renal pelvis, so thickening of the ureters and the renal pelvis. Ureters, renal pelvis. Renal pyramids. Have increased echogenicity. Infection. Diffuse or localized. Power Doppler, color Doppler. Will demonstrate areas of reduced vascularity. Area of infection. So it's a little counterintuitive. You'd think you'd put color Doppler on an area that's infected would light up bright with color. You know, you think maybe it's hyperemic. Typically, you would see that in an infectious process, but with acute pyelonephritis, when you put your power Doppler on, specifically power Doppler, the doctors like to use, you'll get a focal area of hypoperfusion, so very low color flow. And it'll be quite noticeable, like the rest of the kidney will light up and you'll see a small segment, you know, that doesn't look like it's getting the same vascularity to it. So that could be your potential area of the infection. That area of the kidney will typically look more heterogeneous than the rest of it. So that could be your localized area of acute pyelonephritis. So put your color and power Doppler on, particularly your power Doppler, over your kidney, and look for any areas of hypoperfusion or low vascularity, reduced vascularity, so reduced color flow. So as the infection begins to wall itself into an abscess formation, mixed echogenic pattern is demonstrated within the renal parenchyma. So sonography may be useful in following patients after antibiotic therapy has been given to demonstrate shrinking of the lesion. Acute pyelonephritis, antibiotics. Antibiotics are given. Patient monitored. Serial ultrasounds. To ensure reduction, improvement. Chronic pyelonephritis. So patients can also have multiple episodes of acute pyelonephritis, which can result in chronic pyelonephritis. So results when repeated episodes of acute pyelonephritis cause kidney to become scarred and decrease in size. Let's say a result. Repeated infections. Kidney becomes scarred. And reduced in size. Kidney outline may be irregular. May be irregular. Cortex. Genic. In addition, renal pyramids become difficult to separate from renal parenchyma. So we can have kidney stones in little kids. Not common, but it is possible. So we can have nephrocalcinosis. So calcifications of the renal parenchyma, often in the medulla. Renal. Rarely seen cortex. Underlying causes include receiving long-term furosemide for lung and heart disease, along with other medications, as well as with medullary sponge kidney disease. Seen infants getting long-term spell this right. So this is FURO, Bureau semi. FUROSEMIDE treatment. Heart, lung disease. Other medications. As well as spongy kidney disease, medullary sponge disease. Medullary sponge. Kidney disease. It's going to look like little calcifications seen within the medullary parenchyma, kind of like, along the periphery of the kidney. So you'll get little calcifications in the medullary parenchyma. Another condition that we could potentially encounter would be renal vein thrombosis. So it's most likely to occur in dehydrated or septic infants, and it's more prevalent in infants of diabetic mothers. One or both kidneys may be involved. Renal vein. Thrombosis. Likely occur. Septic. Dehydrated infants. Prevalent in infants diabetic mothers. One or both kidneys involved. You can potentially see renal enlargement. Hematuria, blood in the urine. Proteinuria. And low platelet count. So thrombosis occurs in small in the small intrarenal vessels. Enlarged kidney has non-specific disordered heterogeneous internal echogenicity. If thrombus reaches the renal vein or IVC, it may be directly visualized within these vascular structures. So the thrombosis is going to begin within the kidney and kind of work its way inside out. Thrombosis begins. Renal branches. Thrombosis begins in intrarenal venous branches and progresses referred to renal potentially IVC. So kidney is enlarged with organized heterogeneous internal heterogeneity. So it becomes very heterogeneous and echogenic, and it's very disorganized echogenicity. So may coexist with adrenal hemorrhage. Particularly on left side where the adrenal vein drains directly into the renal vein. Left, where renal vein directly drains renal vein. So there might also be development of calcifications within the involved veins. And our color Doppler is going to be critical for us to help identify whether flow is present, reversed, or even obstructed. So I've had several orders for just assessing the renal veins, to rule out renal vein thrombosis. And with renal vein thrombosis, you're going to begin at the kidney and work your way out, because that's where the thrombus is going to develop within the kidney, working its way out. So we have, next thing is going to be adrenal hemorrhage. Let's get that wrong. Adrenal hemorrhage. Adrenal hemorrhage could be a result of a difficult delivery. Potentially the baby was large in size. Results. Could be due to a large baby. Infants. Diabetic mothers. Hypoxia. At delivery. Septicemia. Shock, all predisposed neonate to adrenal hemorrhage. Hemorrhage is usually found secondary to other complications like uncontrolled bleeding, jaundice, intestinal obstruction, hypertension, adrenal abscess, or even impaired renal function. Usually secondary to other complications. Again, some of those complications could be uncontrolled bleeding, jaundice, intestinal obstruction, hypertension, could be secondary to an adrenal abscess or impaired renal function. So sonographic findings, you're going to have ovoid enlargement of gland or a portion of the gland. Yes, on ultrasound. Enlargement. Gland. Portion. Gland. So appearance can range from anechoic to hyperechoic, or a mixture of echogenicities depending on the extent, age, and severity of the process. Range. Anechoic to hyperechoic. Be A mixture of heterogeneous, so it can appear heterogeneous. This depends on age, severity, extent, of hemorrhage. So newer, fresher, younger hemorrhage is going to appear more anechoic. If the bleed is older, it's going to appear more echogenic or hyperechoic. If it's starting to break down again, you can have heterogeneous appearance to it, mixed anechoic and hyperechoic. So that depends on the age and severity of the hemorrhage, and the extent of the hemorrhage. Again, if you go to the textbook and the PowerPoints, there's quite a few good pictures for an adrenal hemorrhage. You'll see the ovoid appearance to it. And mixed exogenicities could be anywhere, from hyperechoic all the way down to more anechoic. So the last couple of things we're going to talk about are going to be our nephroblastoma and our neuroblastomas. So nephroblastoma. So our nephroblastoma, this is going to be our Wilms tumor. Wilms tumor. So this is the most common intra-abdominal malignant renal tumor in young children. Common. Tumor. Young children. Incidence peaks between ages 2 and 5. Incidence. And 5 years. Usually unilateral. And it has a bulky appearance and expands within renal parenchyma, resulting in distortion, displacement of collecting system and capsule. So expands. Renal parenchyma. Displaces collecting system and capsule. So it's typically seen as a large solid mass. Again, it distorts, the renal sinus, the pyramids, cortex, and contour of the kidney. There's large solid mass. May even protrude into hepatic capsule. It's on the right kidney, it might get so large that it's now protruding into the hepatic capsule. May result in hydronephrosis. So there could be hydronephrosis present. With ultrasound, we want to also detect tumor extension into renal vein, IVC, and even potentially right atrium. Detect extension. Vein. See. Potentially atrium. You also want to interrogate the contralateral kidney as well. Even though it is typically a solitary lesion, it could potentially be bilateral. Spreads through direct extension into the renal sinus and the peripelvic soft tissues. Can spread into the lymph nodes in the renal hilum and periaortic areas. There could be extension into lymph nodes as well. Possible extension to lymph nodes. Renal hilum. and para-aortic. So again, we said it appears as a large solid mass. So it can appear homogeneous or as a large solid mass, which range homogeneous to complex. Usually has areas of echogenicity. Area usually has areas are echogenic. They contain classifications. If you see any areas of liquefaction or any anechoic areas, this may represent necrosis and hemorrhage. So, anechoic areas may represent liquefaction as a result of necrosis or hemorrhage. So the Wilms tumor will have well-defined borders. With hyper to hypo echoic ring. Adjacent renal tissue becomes compressed with the mass of growth of the mass. In addition to hepatoblastoma and Pancreatoblastoma, the Beckwith-Weidman also predisposes a child to developing a Wilms tumor, or a Wilms tumor may occur spontaneously. So it could be in conjunction to other blastomas, or may occur independently. Differential for Wilms tumor for children less than 1 year old is neuroblastoma and congenital mesoblastic nephroma. This is also known as a fetal renal hamartoma. All right, so a couple other malignant tumors. We have a congenital mesoblastic nephroma. Plastic. So this is the most common renal tumor of a neonate. The Wilms tumor is going to be in our infant and young children, but in neonates, the congenital mesoblastic nephroma is the most common. It's a rare benign tumor indistinguishable from Wilms tumor by any method of imaging, and tumor may invade adjacent structures. Unable to differentiate. Wilms tumor. Tumor invade adjacent structures. We have the neuroblastoma. All right, so neuroblastoma is a malignant tumor, arises in the sympathetic chain of ganglia and the adrenal medulla. Arises nervous ganglia. That's where it gets its name neural, because it's associated with the nerves. It's a nerve tumor. So it arises in the sympathetic nervous chain ganglia, the ganglia of the sympathetic nerves that innervate the adrenal gland. And adrenal medulla. It's the most common malignancy in children under 1 year. It's the second most common abdominal tumor of childhood, occurring between ages of 2 months to 2 years. Second common abdominal tumor. Childhood. And the age range typically 2 months, 2 years. So neuroblastomas, they're going to appear highly echogenic. And there might be calcification present. So here's highly with possible internal calcifications. Smaller tumors appear more homogeneous. Larger tumors are more complex. So since this is a tumor of the adrenal gland, the kidney is typically displaced inferiorly since the adrenal gland is on top of the kidneys. The weight of that tumor can displace that kidney inferiorly and at times laterally. So, kidney is displaced inferiorly. Laterally. Inferiorly, also potentially laterally. to renal tumor. Doppler evaluation may help to differentiate tumor from adrenal hemorrhage because of increased vascularity within the neoplastic growth. So use color Doppler. To identify increased internal vascularity within mass. So put your color docs on any mass that you see, any structure. You know, when you're doing ultrasound, you're always going to put your color box on to determine vascularity, if there's vascularity within the lesion. So we can differentiate between an adrenal hemorrhage versus a neuroblastoma by putting our color Doppler on. So a neuroblastoma is going to have increased vascularity within that mass. So that's that, you know, malignant neovascularity that develops with malignant tumors. Some other malignant retroperitoneal tumors that we could potentially encounter could also be our renal cell carcinoma, rhabdomyosarcoma, on the adrenal glands, you could potentially encounter adrenocortical carcinoma or a phenochromoscytoma. Tumors. So the retroperitoneum. RCC or renal cell carcinoma. Rhabdo, myosarcoma. Within the adrenals. You have adrenocortical carcinoma. Cortical carcinoma. Or phenochromoscytoma. So again, go into your textbooks, go onto the PowerPoint, you know, look at the pictures, familiarize yourself with the images. You know, Wolff's tumor, it's going to be large, it's going to have well-defined borders, it's going to displace the kidney parenchyma. You could have invasion or extension into the renal vein, IVC. So those are some of the things you have to look for. So have well-defined border with either hypoechoic or hyperechoic rim to it. The neuroblastoma is going to be a lesion of the adrenal gland or the sympathetic ganglia chain, adjacent to that adrenal gland. And the neuroblastoma is going to be highly echogenic with increased vascularity to it to distinguish it from an adrenal hemorrhage. All right, so it is 10 o'clock now. You guys want to come back 10:45? Give you 45 minutes. I appreciate you giving me the extra time. I don't think I'm going to need the full 2 hours for the venous reports. So we'll come back 10:45. All right. Thank you.
Thank you.
Thanks, man.